Okay, well, Olga, thank you very much for your nice presentation. It has been really long. I suppose I'm really important. So, but I also want to thank you for the invitation and the opportunity to discuss with you about the topic of myopia management, which is a field of my professional practice that I've been involved since my graduation, which is more than 40 years ago. So during the last decade, myopia management became really popular. And it became really popular because the incidence did increase very much. Well, Europe was founded in 2011 as the European Academy of Optometry, but in 2014, it became the European Academy of Orthokeratology and Myopia Control because both Kerry Hertzberg, which you know very well, and myself was firmly convinced of the necessity to expand our mission to the management of the myopic progression. The International Academy then also became, and all the continental section of this International Academy became also involved with myopia management, with a particular interest in orthokeratology. So myopia management through the control of myopic progression represents an essential field of practice, both in optometry and ophthalmology. Myopia management must become a service of primary care. It's an essential part of our clinic. Every eye care provider should offer this service. Our academic background gave us all the skills to evaluate and diagnose eye and visual problem. I consider the eye as a structure to be investigated in terms of integrity and vision to be evaluated as a function and then in terms of visual performance. Another reason why myopia management is important is because we have now a wide range of strategies to counteract this progression, which is increasing through the years. So Europe, through the years, have developed a protocol for a safe practice of orthokeratology. It was done in 2015 in Budapest, but we are also proud to have recently approved and adopted a document with the recommendation for myopia management. And this was some months ago, 2019 inclusion. These documents are available on our website. Our members are invited to follow this recommendation, which will permit to manage the field of myopia management of our professional practice for the moment we receive the patient till the moment we discuss the problem with the parents and recommend best strategy for the follow-up of the care that we are going to provide. So it's popular. It's popular, myopia management, because of the incidence. In the left, you have the incidence of the young population, children and teenager. In the 1890s, it was around 20%, as you can see. Now it's more, and it's around 35% in Western countries, while it's still in some area of Africa is very low, 6%. On the right, you have the incidence that will project, and it was in the year 2000 was 25, but we reached over 50% in 30 years. You can see that the incidence here is increasing and moving from 22% in 2000 to 35% now, but will become 50% of worldwide population in 2050. But what is more dangerous and serious is the increasing percentage of eye myopia, which will become 10% in 30 years. Today, one-fifth of youngest in East Asia have eye myopia, and half of them will have probably irreversible vision loss in the future. So the economical impact for the care of this myopia disease is an important issue. Look here, that's a graphic of the Brian Alden Vision Institute. We can see the shift from the year 2016 to the myopic refractive error that will be in just 3 years. So the mean refraction error will shift and shift. We have a shift toward myopia. Which are the risks of myopia? Well, we can see here that the more the eye is myopic, the more the incidence will increase. Over -5, you see that 26% more chance to develop a disease. You can see also that for about -7 and -9, retinal detachment and also myopic retinopathy dramatically increase by 40%, and over -7 to 125 more time. So it's a serious condition that we have to take care. And what we have to try to do is to keep myopia low. Keeping myopia lower than 4 diopters, we have a reasonable, we can control it quite well. Over -4, -5 is becoming really serious. So in this right side of the slide, you have the mean axial length from population from the people that has 80 years ago, 80 years, or people which is 40 years. And you see that the axial length increased from 23 to 24 millimeters. What on the right side, what you have is that the situation on 25, if for a myopia of 26, for axial length of 26, you might have an incidence of 25%. But if you have an axial length of 26 to 30, you go 50%. And over 30 millimeters of axial length elongation length, you have 90% of risk of vision impairment. So it's really serious. And we do not have to permit to our patient to arrive to such an elongated eye. Just this is the evolution of myopic maculopathy. You see that just in 9 years, your vision is gone because it's stuck over the macula. This slide is quite important. Why? Because we can see that, you see, -4, it's not even 5% the risk of maculopathy. But if we go to -8, -8 is 40%. So it's quite more serious. How can we keep this refractive error low? -4, we have a lot of patients which has -4. When are we going to start myopia management? I think we have to start very early when the patient is not with myo. We'll see later. So what's the possible causes? Uh, it's very complex. Myopia control is a topic which is quite difficult because it's multifactorial. We have ethnicity, genetic. We have a near task which contribute, but we need much more to get much more information and studies to have, to get the total picture of how myopia develop and what is involved with that. It seems to be really an adaptation to the modernity. We are spending a lot of time inside, working at near, watching computer, cellular phone, tablet. Our posture is static. We are seated. We don't move. We don't have a lot of motor activity. We spend less time outdoor. So our entire lifestyle is changing. What happened in the last few months with the lockdown? I've started seeing patients, children, and they spend hours and hours inside, working computer, reading, playing on tablets. Myopia is increasing. This is an adaptation to the modernity. Look at this. This is really, really important for us. Our lifestyle did change completely. In the past, 80 years ago, maybe 50, even 50 years ago, we're used to play outside. People was working manually. They have continuous change of accommodation and convergence. Was manual activity. Now we are seated, we have a static posture, we have a static accommodation, a static convergence, because we are always fixated or at a certain point. Our work distance is short, even the cellular phone, the mean working distance for the cellular phone is 22 centimeters, which is very close. And the most it's going close, the most will be bidimensional. So bidimensional is intellectual. It was not like in the past. It was manual, it was a lot of motor, a lot of changing of accommodation and convergence. Now it's totally different. So what are the risk factor? The family, well, of course, genetic, the ethnicity. East Asian have an incidence which is very high. Ocular pathology in the family, the refractive status. We have a decrease of hyperopia. And as soon as we see a changement and a decrease in hyperopia, if we see that the axial length is increasing, that's a bad sign. We have to start working even if the child is not myo. I'm sorry. We have to start early. And this is important. So lifestyle with what I said, that we are always fixed at a point, and axial growth is really important. So if we see, we see refractor error, which is decreasing in hyperopia, and axial length is increasing. And that's something that we have. Well, genetic. low risk, no myopia in the family. One parent, three times more. Two parents, it's increasing to 6 times more. So it's a question of is a question of genetics. Of course, if we add to this, two parents be myope and the child becomes myope, and we have that he's working very long for a certain amount of hours, doing homework at home, playing cellular phone and tablets and computers, it may increase to 52 more times, which is dramatic. So the family, if you see here that if one child has a parents which is myope, the chance is that he will develop 20.25 per year of myopia. If two parents, it's increasing more. It's in here you see that there are two studies. One study is an Australian study that is in, of course, East Asia and East Asian living in Australia have 8 times more risk of becoming nearsighted compared to the Caucasian population. In another study done in England, you see that Southeast can be 23 more time chance to be myope that black or European white Caucasian children. Here too, you see that East Asian compared to Caucasian, and Singapore is even more than China because they're really focused and really there is a real competition in school. The children fight to be the best, and that's really making the change dramatic sometimes. So the most important factor to make myopia progression faster is the age of the onset. At what age does the child become nearsighted? What do we have to do? Can we prevent? Can we try to prevent myopia? What do we have to consider when we have a child with hyper? See that. You see that a child which is 7 years old, as 7 years can progress almost 1 diopter per child which is 11 years may progress 0.50, half a diopter per year. A child which is 14 may progress 1/4 of diopter per year. What does he have to get from this good slide of Brian Alden Vision Institute? It means that we have to try to delay the onset. Delay. Now, can we delay if we just act in a passive way, just making refraction correct? Not really. We'll see that later. So, is refractive error a predictor of myopia onset? 1.5% can be safe, according to 0.75 or less. It's at risk. at age 6. At age 8, 50% is at risk. At age 10, 25% is at risk. And look here. Here, if a child is starting myopia with -1 age 7, it may become -6 when he will be 16. If we're starting with -1 at 9, maybe 4. If we start at age 11, to 3. So we have to do something to make this onset of myopia delay. This is a nice slide. You see what happened 20 years ago. The mother had to put the child inside. Now the mother has to take the child outside, removing the cellular phone because they're always beside that they're watching videos, everything. Nice slide. Look here. This is the mean number of homework hours that a child do per week. On the right, you have China. Immediately after, you have Russia. So there you have almost 14 hours per week of homework in China. You have 10 hours in Russia. Italy is not far from that. But Finland, they have a different education. No homework. Myopia is lower. So in those countries, I mean, China, probably Russia, there is a lot of competition in school. And the family educate the child to fight for being better. And this is, of course, interesting stuff because it creates some stimulation of the central nervous system when you're in that situation. Here, studies show that the outdoor play at good sunlight is effective for prevention of myopia. It does not really work for myopia control. So it means that the children as more as possible to be out and play with good sunlight because that make onset of myopia be delayed. So that's what we have to do. So, and we recommend at least or around 2 hours per day to stay out and play. That did not happen during this late month during the lockdown. They were almost all in doing homework or working at home. This is interesting. A bright sunlight day outside at 10,000, 100,000 lux of light, while inside in a classroom we have 250. In a house is even less. So there is not enough light. Maybe we have to control that too. But 100,000 lux or 250 is a total different story. So if we are delaying this and if we are going to be more out, we have much less possibility for the eye to delay the onset. So This has been a meta-analysis study, 51 articles. Time outdoor with good light is good in preventing myopia, not really working or effective in knocking down the progression already much out. They need stimulation with short wavelength, violet light, which is 360 to 400 nanometers. But what happened is that there are a lot of ophthalmic lenses and contact lenses, and soft contact lenses too, or hot lenses that block UV. By blocking UV, they block violet light. And that's what children need to have. That's the evidence that we have now. So something we have to reconsider blocking this light for children. Another topic that I love very much is is there evidence there? No, there is no evidence there. But to me, it's common sense. Look at this. Look at this. One is a patient of mine, the child, the other a student. Is it possible to work at that distance? They're all myopes wearing glasses that have been prescribed to correct vision for 6 meters, and they're reading with that and working at 10, 12, 8 centimeters. What's the amount of accommodation they have to do at that distance? Look this picture. Look this child here. Look this child. Here, the right eye has a huge hyperopic defocus. Visual field is constricted to the maximum. On the other eye, field is wide open and, or I would not say myopic defocus, but of course, much less hyperopic defocus. This, and look at the stimuli between the two eyes. This is a total different story. How one eye is performing different than the other. Is this creating myopia? Is this inducing myopia? Is this inducing myopia? There is no evidence, but something needs to be studied. In this study from China, we can see here that they recommend, as a child will never walk at 40 centimeters. We can do the examination of 40 centimeters to a child that is working at 20 centimeters. A 7-year-old child will never, he cannot read at 40 centimeters because his arm is not long enough. So this Chinese study recommend to do the examination at 24, 5 centimeters. And if it's younger, even less. Because it's true. What is the mean reading distance of these children? Many times we see they read here. What is the lag of accommodation for a child which is working at 20? Where is the accommodation? What's the demand of the accommodation is 20 centimeters. What the response of accommodation? Where is the lag? Because if we're reading at 20 centimeters and we see how to evaluate the lag of accommodation, we have the response which is at 50 centimeters. Lag of accommodation is 3 diopters. So these studies say consider doing an examination not at 40 centimeters because the child will not be working at that distance. here the difference of posture of these uh, patient. The posture here of this is a patient of mine. She did autopsy. But even with orthokeratology, the posture is tilted, better, tilted and very close and better posture. You see the difference just using an inclined plane. This is common sense. Does not need to be base evidence. This. Look at this. Look how he's writing. Even the, the writing is crooked. Look at this little girl. We have a lot. I have hundreds. And this is what the Chinese do in order to correct that. I believe that these are artificial that we don't need to do. That just an inclined plane, they will work better and at better working. Now they are using a lot of electronic devices, cellular phone, iPad, computer, and most time they spend this fast, but less time they spend playing and outdoor. And they, they have an addictive mode to this electronics. Look at this. This I was in a at the airport in Paris, and I took in 5 minutes. I took 4 pictures. These were the people that were around me working on cellular phone. Is that a normal working? No, it is not. The visual demand of this task are too much visual demand. That's the same when the child is reading and writing. Look at this. It's not normal. That's the same airport. No communication. I was there 1 hour and a half. And these people did not talk. They did not do anything. They were just sitting there playing with. Yes.
Марина, у нас на эту тему есть 2 вопроса, если можно. Значит, вопрос первый на тему солнечного света и детей. Полезен ли ультрафиолет для детской сетчатки? И вопрос от меня, и в таком случае, как вы относитесь к солнцезащитным очкам у детей? Где найти вот этот баланс?
Yes. Yeah. Okay. There have been a few studies. There have been a study that said that children that have been exposed to UV light, UV light did progress less in myopia. There is another study that is a meta-analysis study say that, and no, not the meta-analysis, the Japanese study said that children need violet light. Violet light is short wavelength. So this means 360, 40 nanometers. They need that light. Now, when we use lenses that block UV light, we are blocking the violet light. If we have the windows now that are blocking, the windows of the houses are blocking UV light. We have a lot of protection from UV light. So, and this is strange because what we did till 2 years ago, we always said children need to wear sunglasses, they need to wear the hat, they need to be protected. If because it's dangerous even for developing cataracts and things like this. Okay. These studies say the contrary. So what should we do? For sure, we need more studies. We need more evidence that proves this. For now, I recommend go out and play. Out, play without anything. Is it correct now to say till 25 years of age, no glass, no protection? After 25 years of age, wear sunglasses. You must wear it because otherwise it's dangerous and you may develop cataract. I spent hours and hours outside playing when I was young. Never wore sunglasses. Have the child wear a hat. That's more than enough. I think that's more than enough. Actually, I do not recommend children to wear sunglasses.
Спасибо большое, Марина.
So let's enter in a topic which is really interesting. That's the part of myopia management that I prefer and I love it. So here, vision environment seems to have a major contribution to myopia development. These two studies show that the risk of myopia development is much higher if you read at a short reading distance of 20 to 30 centimeters for continuous period of time, more than 45 minutes. A lot of people, we are all doing this. All students do this, except dyslexic. They don't like to read. They will not, dyslexic will not become nearsighted. But those that love to read and compete, they could. So let's evaluate what's happened. Let's see what's happened. You see the emmetropization occurs during childhood and is usually ends finish at age of 6. Which is the refractive error that is present at age of 6? Is hyperopia 2 diopters? Good, probably safe. Is hyperopia at age 6 when the emmetropization ends 1 diopter? Not bad. Is 0 to 50 or 0 to 25? That's risky. Let's say that it's 1 diopter at age 6. We see the patient the year after and hyperopia is 0.50. And after we go 2 years to 0.25, we have to act. Now we have another instrument which is really important, which is axial length. If we measure that, usually there is normal axial length is 0.1 millimeters. If axial length elongation is more than 0.1 is 0.3, that's the bad sign. We have to do. So eye variation or refractive power, specifically hyperopia, occurs 2 years before myopia onset. Axial length elongation increases, accelerates in the year before myopia onset. ACA relationship change before the onset of myopia and start 4 years before onset of myopia. So we have ACA increasing before the onset of myopia. What does it means we have convergence and near. We have a tendency to have euphoria. Okay, so this occurs between the age of 6 and 12. That's years where the myopia can start. That's the year that's the year that we have to evaluate the child, but not only refraction. Only refraction, we act in a passive way. We have to be active. We have to do something to prevent. This study say that if a child at the age of 8.5 is having 0.75 of hyperopia, have a sensitivity of 87% and a specificity of 75% to become myope. 0.75, 8.5. That's critical. This is what Radnick modified. And you see, 125 at age 5 is risky. The red area, dangerous. We are safe on the green area, but green area means what? Means having one diopter at age 8 or 9. That's okay. I have patients that were 150 of hyperopia at the age 5 or 6 that did became myope at high school. So short distance of less of 20 centimeters is critical. Continuous work for longer 45 minutes is critical too. And that's increasing the risk of developing hyperopia. We have the tool. We have it. Normal phoropters, the normal instrument we have in our office. A topographer, if you want to do optokeratology. What's extremely important now is axial length equipment. So evaluate the refraction, measure axial length, you're going to manage it. You're going to see what's happening in a child, which is in elementary school, for instance. So what's happening? What are the characteristics of the myopic profile? Progressive myopes exhibit an accommodative behavior characterized by high response lag that increases the demand. What does it mean? The more the child is really close, the higher is the lag of accommodation. Elevated ACA response. When do we have high ACA? We have an ACAs where the phoria is also normal at distance and is over converging in near. When we have esophoria near, that's an high ACA. And this is a characteristic of the visual behavior of a child which is becoming myope. So esophoria near. Higher lag of accommodation, sure, and reduced accommodative flexibility. It means the ability to stimulate and relax the accommodation is weak. So when you have esophoria, when you have high lag of accommodation, and when you have use accommodative flexibility, which can be done with a simple clicker, which you know, for instance, with minus, which is characteristic of a high ACA relationship, what do you have to do? You have to give plus. So here we are. We are coming there. Look here. We have the normal eye examination, case history, visual acuity, refraction, and then ocular integrity. But refraction tells nothing. Refraction just tells you about the refractive error. It tells nothing about the accommodation. It tells nothing about the lag of accommodation. It tells nothing about the amplitude of accommodation. It tells nothing about the flexibility. It tells nothing about the convergence. Now, do we really want to delay myopia onset? ACA relationship change before 4 years. Hyperopia decreased 2 years before. When we see this, we have to ask. If one parent is myope, two parents are myope, we have to ask. Brian Aldiss used to say, start myopia management strategy as soon as is minus 0.50. No, I don't agree with you. We have to act between plus 0.50. So I'm proud of this because I developed this examination, which can give you in 10 to 12 minutes more than the normal examination that you do. I'm not talking about the whole examination. I'm talking 10 to 12 minutes more to evaluate binocular vision of the child. So refraction, there is nothing nothing new there. Everybody knows how to do a refraction, manifest refraction, psychoplegic refraction. Psychoplegic refraction has to be done at the end. At the end, you cannot evaluate binocular vision psychoplegic after psychoplegic refraction. So you have to evaluate the visual performance before, and then eventually you do psychoplegic. Okay, so the only new thing there in the refraction is what you see is these delayed subjective techniques. I like it very much. I do it every time I do an examination in a youngster. It's excellent for latent hyperopia and is excellent for children to be evaluated for myopia. So, for instance, here in Italy, optometrists are not allowed to use drugs. They're not allowed to do so I have to tell to my student to be sure to give the right amount of finance. And we have to be really careful. So if we want the right amount of binance, you are going to be slow with your refraction. You have the fogging technique. So you do retinoscopy, then you fog two diopters, then you are going to go and correct the vision with your normal refraction. You have 10-10, and so you're doing the refraction at distance, and then you do all your examination near. And at near, you measure the amplitude of accommodation. Then you're going to measure the flexibility in the ability of the patient to stimulate accommodation and to relax. So you stimulate the accommodation with the minus and you see what it gets. Then you blur totally at near with plus so that the patient cannot see nothing, can't see anything at near. Okay? So it cannot see anything here. You relax accommodation at the maximum. Now you take your reading chart and you look at far. It's totally blurry, because if it was blurry here, is even more blurry from this. So you are going to have the phoropter. You decrease the plus binocularly 0.25, and you ask the patient, tell me when you start reading. And you go 24 to 20, you're up to 2020 or 1010. And what's the power of the lens that permits you to see 1010? That amount of diopter is usually different of the amount that you measure initially, because you totally relax the accommodation close. This is a procedure. It's not a procedure that I did invent. Dr. Borish, optometrist in the United States 50 years ago, was talking about this delayed subjective technique. Can we measure lag of accommodation? It's very easy. You ask the child to read, and you are going to do retinoscopy at near. You put yourself with the retinoscope here, and you don't put lenses. That is called not retinoscopy. You're not going to put lenses. You're going to move. If you see a with movement, you go further. If you see an against movement, you move. So where do we have to go? Okay, so let's measure the lag of the procedure, all this examination, all this technique of visual examination, I made video presentation that are available on UROC website. You will see after. So we have lag of accommodation that can be measured with not retinopathy. Accommodative flexibility, we have a flipper, +2, -2 flip, and we can do it to measure monocularly or binocularly. Binocularly measure accommodation and convergence. Monocularly just measure accommodation. So we can even see if the minus is low, minus is low, monocular is a commodity problem. If it's binocular, is low with minus, can be a convergent excess, or it can be a commodity with insufficiency. But we have to do both. First we do binocularly, after we do monocularly, and then we can see. Also, we have foria. You just measure the foria from far, and you can measure the foria from near, and you can have the ACA relationship with that. That's important. The foria here is myopia. If you have ESO, you have to give plus. Accommodative flexibility. We measure the lag of accommodation, then we measure the flexibility of accommodation. We measure the foria, and then we measure the vergence flexibility. So if we have a esophoria and we have a prismatic flipper which is low with base in, which means that the reserve for esophoria are not strong enough to compensate, we have to give plus. So we have lag of accommodation, we have accommodative flexibility, we have foria, we have vergence flexibility, and we have one more important. I want to know what is the component, where is the see clear, which distance. And you can have it. You have the performance, and you can, with this test, in 10 to 12 minutes, you can do a simple diagnosis of a vision dysfunction problem. Your strategy or even the prevention is all working in this field. Myopia prevention is all working in this field. If our duty is to delay the onset, with this way, only with this way we can delay the onset. So here you have in the website, that's I'm explaining what I'm doing. This is what happened when we prescribe a pair of glasses. This is the evaluation, how we measure the lag of accommodation, the near point of convergence, the flexibility of the accommodative emergence system. And after, finally, I get to the diagnosis of binocular vision dysfunction. You see a retinoscope, a prism bar, flippers, and a pen light. That's all you need. With this instrument, you can evaluate in 10 minutes the performance of the child. This is extremely important, extremely important. Without this, I don't think we can do myopia management. Strategies. We are short in time. We are going to do it and see what's important. The most important thing is, as we said, prevention of myopia. Make the child go out and play on the good side without restriction for now. First thing, prevention. Outdoor at least 2 hours per day, which is good to prevent. It reduced the onset of myopia by 50%. Does not slow progression. There are a few studies that say, no, it's not really working. But we see that what's important is spectral composition of light, short wavelength, violet light, UV and violet light. That's what the child needs to. We have done our examination. We have done all the examination considering the binocular vision. We have to discuss the problem with the patient and discuss also the strategy which is optimum for the child. We can have we can have contact lenses, peripheral plus strategies, pharmacological treatment. Here they are summarized all. Not really, because single vision spectacles and single vision soft contact lenses are not really myopia control strategy. Giving and correcting vision, giving full prescription to wear full time will make myopia increase by 0.75 to 1 diopter per year. Usually, that's the same with spectacle or single vision soft contact lenses. So the strategies really are peripheral plus spectacle, bifocal progressive lenses, soft contact lenses with peripheral plus, orthokeratology. We are going single vision is not really good, is increasing C 0.50 to 1 diopter per year. It serves only as a control. In studies, it serves as a control to compare with the other strategy, but it's not really effective for myopia control. Undercorrection does not seem to work. they have undercorrect 0.75, and they have seen that myopia did increase more than with the full correction. A study showed that minus one diopter, not wearing glasses, did increase less than full time. So we need more study there. But in any way, let's say that undercorrection is not working. Spectacles are working quite good. Let's say that the most effective are the executive bifocal, which in study made by Chen is decreasing by 40%. Progressive lens is working less. That's for the executive bifocal. You see spherical equivalent is reduced by 35 to 1%. Axial lens 34, which is not bad at all. This is good. Okay, what's important here? Where do you put the segment? In a presbyope, you put the lid. You don't put it on the lid. You put on the inferior pupil margin. Sometimes I put even higher. This is the reason why I don't like much progressive lenses. Why? Because when the child is working at close and he has a big book and he's working like this, he will not use progressive lens. I have to do this. The child will never do this. So we'll use the top part. So we have to put the segment height very, very. Also, really modest myopia reduction comfort, 10-20% with progressive lenses. Using progressive lens, it's important to use short corridor, not long corridor, short corridor, so that you can have the plus better. PC's peripheral plus spectacles, they're available now. They start to be available now in Europe and wide. It's like to have a progressive lenses with plus all around. So it's a 360 degrees plus. You must have enough because you must have myopic defocus. So add is important. We cannot give an add of 0.50 or one diopter. We have to give more than one. This is a new lens. This is new lens developed by Hoya. So in this lens, which is quite effective, spherical equivalent 25%, axial length reduction 31% is good. You have what? You have a central area of 9 millimeter for distance. And all around this distant vision, you have a 33 millimeter area of disc of 1 millimeter 0.03, which gives with an add of 350. Here, this is important because you see that if we have a child which is starting -1 at age 7, and we continue with single vision, we will become -7. If we have 20% control, it will become -550. If we have a 40% control, it can become -40. 450 -7 is a different story. So the take-home message is what? Is to delay the onset the more we can, and we can do it with good information, and after with a good strategy. If he's already myope at 7 with -1, Well, you have to really choose the best practice. Single vision soft contact lenses are not working. Look at this study. This study has been done in Australia. The lenses should be -6. The -6 lenses, you see that at the center, this is the eccentricity. At the center, there are lenses that are -650. There are others that are -550. So someone is over and someone is under corrected. But what you hear is that the power is increasing, going on the periphery of the lens. And they're all more myopes, stronger. This is bad. This is increasing even more at top of the box. There is only one lens, which is not doing that. This is the night vision. Night vision. No, it's night and day. Okay, but this has a particularly optic. It's a flat dioptric optic. So that's why probably this lens is better because it's not stronger in the periphery of the lens. Contact lenses. We can control myopia. These are the studies. We can usually control myopia from 30% to 50%, depending on the study. Different type of correction and optic. I'm not going to discuss that now. We don't have problem. We don't have time enough. But what is important with the soft is that they can be worn. The people is comfortable. They are going to be worn, of course, for daily wear. There is some risk of corneal problem, as with orthokeratology. They have to be worn full day. These are plus on the periphery. People, the children have to study with the lens, so they need to be worn all day. Usually not alternating with glasses, not wear glasses for study. They need to be reading and study with the contact lenses. They can have, they do a myopic defocus depending on the optic through the periphery, especially on small pupil. If you have small pupil, I think it's better to fit soft contact lenses in a low myop. In a low myop, it's better to fit soft contact lenses than if the pupil is small. And if we have an increase of myopia of 0.25 to 0.50 per year, it can be child is increasing, the youngster is increasing 1/4 per year. It's not bad. It's good. 0.50, it can be okay, good. Overnight orthokeratology. This study say that the mean myopia control is by 50%, 48, 50%. This is done with conventional lenses, conventional orthokeratology, which has not been manufactured for myopia control. Conventional orthokeratology is not for myopia. There are reverse geometry. They have a standard optic zone diameter of 6. They have a conventional Jessen factor 0.50 or 0.75. These lenses are being designed for people to alternate the glasses, not for not wearing glasses. So it means for adults. Now, can we have a different can that be better with special orthokeratology? designed for myopia control? Yes, probably. Yes. Here, the studies say that myopia control, myopia control with autokeratology is around 45% with 50%, and it's safe. This is a meta-analysis, so is solid. And let's say that to control that, we can have a eye myopia reduction by 90%, which is excellent. Do better. The weakness orthokeratology for orthokeratology. The field of myopia. In the next slide here, you see that axial length with orthokeratology. It works very well from 3 diopters and all. It's good. Here, not good at all. This is -1, -2. It's not effective. My orthokeratology is not so effective. Why that? Too large treatment zone. The lower the myopia, the larger the treatment zone. Not enough myopic defocus can be a cause. Not enough action because the force under the reverse curve is not strong enough, maybe. Are we considering or are we neglecting pupil size, which is important? We see how it is. Lenses have not been manufactured for myopia, the conventional one, or can be all this or some other. There are no studies on this. This is look at this. Treatment zone of a -1 myopia. You see, this is the clearance, the tears under the lens. Under the reverse curve of a conventional lens with a anatomy lens with a Jessen factor of 0.75 is 29 microns. That force is not strong enough. Myopic defocus is nothing. Is 1 diopter of myopic defocus is not enough. Or if we increase the Jessen factor, not 0.75, but 150, you see that that's a little better. We have 40 microns. Stronger force. This is a customized lens. Okay? These are customized lenses. So we have a optic zone diameter, which is in this case 5.2. And it's aspheric. You see here, we get to 63 microns in a -1. So instead of 29, we have 63, more than double. This, we want to simulate a -4, -5 treatment in a patient which is -1. So if we want to have more effect, look here. This is one of my patients. This is one of my worst patients I had in orthokeratology. This girl became more myope of 3 diopters in 12 years, I think. Look this. Here, wonderful, great, beautiful. You see here, the pupil size is this. Okay? So it means that the pupil size is here. We have all these huge myopic defocus of several diopters all inside of the pupil. We have it inside of the pupil. And this is really important. Pupil size have been demonstrated to be important And the study of say that the larger the pupil, the more myopia control effect on maxilla elongation. This is another study by Chen. This is important. You see here, in this case, the pupil is small. All you get is through the ray that passed to the flat part. Okay? And you have an hyperopic defocus. The people with orthokeratology lenses get worse than people with single vision glasses in 2 years. So, worse orthokeratology than single vision glasses. We must have this effect. The pupil, the treatment has to be inside the pupil area. If the pupil is inside the pupil is larger than the treatment zone, we can have a myopic defocus. So it's passing through this curve, which is oblate, and did increase the convergence of the ray. So we must have this, not this one. So we must consider pupil size. This is a patient of mine. Look at here. You see the pupil is small. The treatment zone is large. Look, not good. Myopic defocus is minimum. That's another case. Pupil is large. Look here, the refractive map. I have all these huge and beautiful myopic defocus inside the pupil area. And this is what we want to have if we want to have myopia control. This is extremely important to the orthokeratology. So this is a patient that I discussed before. This is the same patient. She was 11 and she was -3. Beautiful treatment. That's what the lens, the fluorescein, the simulation. This is the treatment, well-centered. The pupil is not wide enough for this treatment. This treatment is too big. This is much better. Same patient, much better because what? We have the treatment zone inside the pupil area. So we have myopic defocus, which is important for myopia control. So, my dear Carrie, that's a picture I made in Moscow in 2016. For a better myopia control, we must have a molding which is enough with a strong effect, enough action under the reverse curve, even in low myopia, a small treatment zone. We must have a treatment zone which is 1.5, 2 millimeters. So we have to consider the pupil size, and myopic defocus has to be all inside the pupil area. And now we enter in a different field. Eye myopia. I think that this is extremely important. I'm really proud. I'm one that was between early people that think about this. So it's a orthokeratology to be worn daytime. When you are over -6, what are you doing? in China. What are they doing after the people, when the people is -5? They cannot fit orthokeratology anymore. In Europe, we can have success with higher than that. But what do you do if you have -7? What do you do if you have -8? What do you do if you have -11? I have I have teenagers that are -1 with -3. What do you do? -9 with -3. I have another one, -11 with -4. What do you do? You cannot do orthokeratology. I will not. There are lenses that can maybe work. I don't do it. I don't feel comfortable. To me, is to stress the cornea too much. I prefer to fit daytime orthokeratology. So I do orthokeratology. It's a top. It's a effect is low. The treatment zone is large because you are going to make a reduction of 1 diopter and a half or 2 diopters. Okay. So it can be worn during the day, usually comfortable, and you can correct, no limit. There are no correction limits. I did it -20. So they have a mild effect of -150 to 2 diopter effect. Like for myopia, we use IDK material like the daytime. They are reverse geometry, and total diameter of the lens is not so big as daytime. It can be 10, 1020, 1040, 1050 maximum. But I did even do more than that. And they are aspheric, and they have an asphericity on the external. As the treatment zone will be large because I'm going to have a 150 to 2 diopters effect on the treatment zone large. I will have a myopic defocus because I will give an add of 3, 4 diopters using a negative asphericity on it's excellent. Of course, you can do orthokeratology till -6 and after give a pair of glasses to look at far. I prefer my lenses because they don't have to wear glasses. So they wear the lens all day and they are good for distance and for reading. So that to me is the future because we have to control myopia starting with prevention, 50 plus 0.50 plus 0.75. But we are going to do, we can use atropine, we can use soft contact lenses, we can use up to 6 degrees of myopia. Maybe the only chance we have to control. Atropine. Good. That has been using since certain numbers of years. Most of the time we use diluted 100%, so 0.01%. But this is a study that came out last year at ARVO 2018. It shows that spherical equivalent is control is 27, but axial length 12%. Is reducing axial length agglomeration by only 12%. That's not seems to be enough. And we have in clinical practice, we still have some we can document every day that every time that myopia still increases sometime with atrophy. And this study is what? Couple of weeks. That's the control with orthokeratology and with 0.02 atrophy after 2 years. We see that the elongation is less with orthokeratology than with 0.02 atropine. So we have tools. We have tools to control. So what is the conclusion? When do we have to start? I told you. We have to start very early. Look here. I would say prevention. When you have high risk factor with two parents myopic or one parent with eye myopia or ethnicity is Asian, we see that hyperopia is decreasing or we have emmetropia. We see that acceptance elongation is increasing more than 0.1 per year. Then we are going to evaluate binocular vision. So we have an isophoria for near. It means IOCA. So we have a high lag of accommodation. Do we have a reduced accommodative flexibility? Do we have a reduced urgence flexibility? This means, do we have a diagnosis of accommodative insufficiency or do we have a diagnosis of convergent excess? If yes, first, correct hyperopia. Second, give an. You are using tools to delay myopia onset. We have to delay. Follow up every 6 months. We are going to do that. We are going to follow up the child every 6 months. Make your patient feel special. If not, and in any way, we have to recommend go outside, play outside, eat well, control your posture, read a good reading distance. If there is no eye lag, there is no esophoria, there is no reduced flexibility, you just control every 6 months or every year, and that's okay. They see that you're taking care of the patient. If age is less than 10 and you have already myopia, high risk. What are we going to do? You see there, let's see, with myopia from 0 to -3. What can we do? Ophthalmic lenses, we can give progressive lenses, we can give an app for near, we can give bifocals or peripheral plus. We are going to use contact lenses. This is low myopia. Check pupil size. Is the pupil small? If the pupil is small, you're better to prescribe or glasses or soft contact lenses with an ad for near. Or you have to do myopia control design lenses, which are thought to be available, or you can have design lenses, customized lenses. You design your own lenses. That's great. I do it. Or you can use, if the pupil is wide, you have a pupil which is more than 5 millimeters. If more than 5 millimeters, you can use a conventional orthokeratology. Why? Because the treatment zone is the pupil size is large enough, and you can have an effect because it's inside the treatment zone. You can use soft lenses. You can use design lenses. Sorry, I don't. The image is too small. Now here you have from -3 to -6. You can do glasses. This is not the preferred strategy. You can use contact lenses. You can use the pupil size is large enough. Now from three to six, pupil treatment zone is large enough. Is working with conventional orthokeratology too. You can work with the soft contact lenses. You can work with so pupil size is not really important if you have a myopia which is more than -3. If it's -4, -5, -6, in any way with a normal pupil size, we can be comfortable. We can be comfortable. So we can have a good effect with that. Of course, we can use atropine, and if one of these strategies is not working well enough, you can always add atropine, or you can add an optical strategy over atropine. Over -6, you have to start over -6. You have to start considering, is atropine effective? Well, if you're already -6 and over -6, -6, -10, that's really hard. Spectacle vision is not great. Aesthetic is not perfect. There might be some orthokeratology which can be effective in special design contact lenses. There are companies that are specialized on that. But what is important here is daytime orthokeratology, in my opinion. That's optimal choice. And over -10, you just have that. Just have, well, even atropine over -10, daytime orthokeratology, that's the future in my. So we are really at the end. What the take-home message here? So what do? We have to delay myopia onset. The most important thing is to take care of the child and delay myopia onset. It's important. We must, all eye care providers must include myopia management on their practice. We have to consider not only the eye, not only the structure of the eye and the integrity of the eye. We have to consider vision. We have to consider binocular vision. We have to consider visual performance. We have to start early. We have to consider prevention. We must become specialists and be able to provide the most effective strategy in myopia management. And we must make our patient to feel special. You will be rewarded. Thank you.